You're listening to Medscape's In Discussion series on urinary tract infections, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Lenore Ackerman, Associate Professor of Urology and the Director of Research in the Division of Urogynecology and Reconstructive Pelvic Surgery at the University of California, Los Angeles. Relevant disclosures can be found with the episode show notes on Medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for use healthcare professionals.
Hello, I'm Dr. Lenore Ackerman, and welcome to the Medscape In Discussion podcast series on urinary tract infections. Today, we're focusing on some recent changes in the guidelines for the management and diagnosis of cystitis with our very special guest, Dr. Barbara Trautner. Dr. Trautner is co-director of the Division of Infectious Diseases at Washington University in St. Louis and co-chair of the Infectious Disease Society of America UTI Guidelines panel. Welcome to the Medscape In Discussion Urinary Tract Infection podcast.
Well, thank you for having me. As you know, I love to talk about UTIs, so this should be fun.
I have so many questions to ask you about some of the recent revisions in sort of how we approach cystitis and the new IDSA guidelines that have come out very recently. I kind of want to kick this off with a question that I keep getting from lots of my colleagues that focuses on the new focus in the guidelines about differentiating instead of the old framework of thinking of patients as complicated or uncomplicated, but now focusing a little bit more on the infection itself being a localized infection versus a systemic infection. Maybe to start off, can you talk a little bit about what sort of motivated that paradigm shift from complicated, uncomplicated to this more localized versus systemic paradigm?
So, what motivated the shift is first the panel sat down and wrote our PICO questions, which basically fell into like the categories of like cystitis, complicated UTI, UTI in men. And then we had to decide where we wanted to focus our attention first. And we all felt that there were some existing guidelines for managing cystitis, but there was nothing about managing UTI in any other population other than premenopausal women. And I've been a practitioner at the Houston VA for most of my career, and I take care of a lot of men. And it always bothered me that we didn't have guidelines that applied to UTI in men. So that's how the panel started out and decided we were going to work on complicated UTI guidelines first rather than uncomplicated, because there were no guidelines for complicated from IDSA. But how did we rearrange what counted as complicated or uncomplicated? Well, we really just went with aligning with current practice. Cal Gupta, author of the prior cystitis guidelines, is on the panel and just pointed out that it was important to think that the way we are managing UTI now relates to where is the infection located, because where the infection is located determines not only your choice of antibiotics, but often how you're going to manage the patient, inpatient versus outpatient. So that's why we went with defining complicated UTI as an infection that has spread beyond the bladder, and infections confined to the bladder are uncomplicated.
Do you feel like we can take the prior literature that really classified patients, if there was a clinical trial that looked at uncomplicated UTIs or that looked at complicated UTIs, is it fair to kind of take that literature and just kind of sub in the new terms and treat that data from the standpoint of saying, if we're thinking it's uncomplicated, we can use those studies to apply to localized, and the alternative where if it was studying complicated, can we use that to talk about systemic infections? Or does there have to be sort of a whole new body of literature that comes around as we start to think about reclassifying these concepts?
Yeah, that's an important question. I don't think you have to discard all of the literature of the past, but you have to look at it and decide where it fits in. I think the problem with the older classifications is that there was the concept of acute uncomplicated pyelonephritis. And that's a concept that's just hard to support. I mean, pyelonephritis, once the infection is in the kidney, uh, it's more of a problem than it is cystitis. And it is kind of hard to define who had this acute uncomplicated pyelo. So all pyelonephritis now falls under complicated. So if you go back and look at the literature, or even what we included in the guidelines, we included any new literature since 2008 with the prior guidelines. A lot of our trials that went into the evidence base for complicated UTI were all trials of pyelonephritis, but we're calling that complicated now. So it's just look at it. What percentage of the people in the trial do you think had cystitis versus what percentage had something else, and interpret from there.
That's great. I personally, I think am really excited about this sort of new framework because, like you said, if you treat men at all with this older concept that all men had a complicated infection required these, much higher sort of level of broad spectrum antibiotics, and it always just kind of felt wrong to treat something that looked pretty localized and not that same level of systemic or really higher risk infection to treat these more localized things as this very scary and expose patients to much broader spectrum and higher doses of antibiotics. So I really am very excited about this paradigm shift and think it will make a really big difference for people. To follow along with that, what do you think is sort of the way that this is going to impact the day-to-day practice for physicians who are kind of that first touch for a lot of patients with UTI? What do you think is or could be the big change, I think, for how those providers interact with patients who are coming in with urinary tract infections?
Well, I know how I hope it will work. And you are correct. Our guidelines are written for first touch providers. We had emergency medicine on the panel, primary care on the panel, hospital medicine on the panel. So they're not really written for the ID doctors, but they're for all these other groups too, and particularly for pharmacists and ID pharmacists. We've hoped the guidelines reached our audience with them. I hope it will help primary care providers to recognize that men can have an infection that we think is confined to the bladder. Now, keep in mind, complicated versus uncomplicated does not tell you how long you treat the infection in men versus women. We still need a chance to do the uncomplicated. Men may prove to need a longer duration than 3 days. They may need 7 days. Some of that may be there's a bias that men don't have UTIs as much as women. So they may present slightly later with more, bladder wall invasion or something. I don't know. I haven't looked at the evidence yet on duration in men in uncomplicated UTI. But I hope that these can be applied at the point of care where people can say, I've got it. This is an uncomplicated UTI and I don't need systemic antibiotics. I can use something that is only in the bladder.
That's wonderful. Also, kind of looking at there's been updates in the IDSA guidelines for complicated UTIs, and then an update recently for the American Urological Associations and EAU guidelines. When we think about all of those guidelines together, it actually to me doesn't quite cover all of the populations. We have sort of, individual sort of niches that cover different groups and they sort of a little bit overlap. But I think there's a greater trend in all of those guidelines towards focusing around symptom resolution and individualized risk benefit decisions rather than I think how things were sort of perceived 20 years ago as being more about microbial eradication. You mentioned earlier in your discussion that we don't really have a lot of great guidelines for patients with these complicated UTIs, and that a lot of how we view cystitis really is based on data that comes from very sort of at baseline healthy populations, sort of a 20 something year old woman who feels pretty normal all the time and has a very distinct set of symptoms that comes on when they get a UTI. And so, can you talk a little bit about how outside of that sort of what the AUA guidelines call the index patient, right? This index population of very uncomplicated, healthy people. How do you think about that risk benefit decision about when to treat patients whose situation may be a little bit more complicated? Maybe they're cognitively a little impaired or neurologically not completely intact, or, they have baseline urinary tract symptoms. I think this is where it really gets hard for a lot of clinicians to know what to do and when to do it. What's your sort of view and the way that the IDSA guidelines have sort of framed some of that discussion about how to look at an individual patient who may not be as straightforward and what to do when they come in with worries about these, do I have an infection or those sorts of things?
I love the way the AUA recurrent UTI guidelines define the index patient so clearly because it shows where our evidence is, which is healthy, mostly premenopausal women. And that opens us up to greater discussion and understanding that we don't really know the index symptoms of UTI in men. Perhaps penile pain is a symptom, but since it's never been studied, we don't know. Um, we also don't really know what symptoms define UTI in people, say, with neurogenic bladders, where they're not sensing their bladder very much. Individuals think they know what may define it, but that doesn't always correlate with what you'll find in the urine and whether or not you need to treat it. So, what I think I would advise clinicians is follow people longitudinally and be brave. And what I mean by that is, say you've got someone that comes in to see you and they think they have recurrent UTIs, and you're not really sure if their urinary frequency or urgency or what they've got right now is related to a UTI, but you get a culture, they've got bacteria, you give them some antibiotics. You need to develop a longitudinal relationship, because if the antibiotics make them feel significantly better, then you know what? Perhaps the bacteria were having a role, or maybe there was a placebo effect. But if the antibiotics don't make them feel significantly better, or everything just recurs right away, that's when I think you need to work with the person and look into how likely is it that you always have bacteria? How much can you deal with in terms of symptoms? When can we ignore this? What is going to need to be our threshold to treat? Are there non antibiotic approaches that we can try to manage you over time? Because some people are going to exist with bacteria all the time and have some low grade symptoms from that. And it's a balancing act of when you need to treat that or not.
So I think one of the biggest populations that can be really challenging is patients that are cognitively impaired, who really can't tell you their symptoms at all. And all you're getting is a story from a caregiver or from a child taking care of a parent saying something like, well, she just seems really off today. I want you to treat her. And, we often find those patients come in and maybe they come into the ER and they get a lot of interventions at that moment. They get hydration and they get antibiotics and they get all this attention. And so then they go home and they feel better. How do we start to dissect when that is the antibiotics and an infection that we're treating versus when it's just other sort of fluctuating parts of the existence of a cognitively impaired older adult that are impacting in their overall health?
Well, there are a lot of us working on that problem for a while. And you see it a lot that people come into the hospital for these recurrent UTIs, but I think we pump them full of fluids and they feel better. I mean, I really think that's probably what we're doing in most of those cases, because the bacteria is just coming right back as soon as we stop the antibiotics. I think we need to do a lot more public education with families about antibiotics aren't good for your relative. So let's avoid them if we can. If this confusion can be managed with fluids, checking the vital signs more often, and taking a look at seeing how they're doing tomorrow, maybe we should do that instead of another round of antibiotics that can have side effects. I mean, different countries feel differently about if antibiotics are always good. In the US, our qualitative work says people think antibiotics are like gold. They're that valuable. But some other countries are like, "Oh, I don't like to take those. They're just bad for my microbiome."
I think that's really true. And that kind of gets to another question about our attitude towards antibiotics, which is, now thinking about the difference between an initial sort of isolated episode of cystitis versus patients that come in with recurrent infections. And I think that there is also a concept that those are different things and that we treat them differently. So maybe you can give me a little feedback on sort of how you view that first cystitis episode versus the recurrent cystitis episode, and what should be the differences between the treatments of those sort of two situations?
Well, clinically, I don't think I've seen the first cystitis episode for people.
Fair enough.
I work with older adults, many of whom are men, or they refer women, generally older, to me in clinic. So there's some research that the first episode, kind of creates an immune memory and an immune response. You may know more about that than I do, but I feel like from a clinical point of view, you're going to manage episodes of cystitis the same. What's going to drive if you need to treat immediately with antibiotics is the patient's degree of symptoms. There are women or men that are so ill with that UTI, they are pacing the floor, they cannot sit down, they are voiding blood, they have bladder spasms. Obviously, the delayed approach of seeing if their symptoms get better is not going to work in that population. But then in someone who presents with more mild symptoms, it's more burning, there's kind of an odor. I'm not sure. Okay, maybe that's someone who you can get a culture collected, urinalysis and culture collected, and maybe hold off on starting antibiotics, maybe encourage more fluids, see if that can clear on its own. So it's an individualized approach based on the severity of symptoms. And then if you've got someone with fever and delirium in the emergency room, you know what I would say? Get the blood cultures. I mean, let blood cultures guide you. The infection is beyond the bladder if it is now in the bloodstream, and that is a clear thing that can help you.
Absolutely. And for a patient maybe seeking care between episodes and they're coming in with recurrent UTIs, I think I've heard the story a lot from patients that say, "Oh, well, I now I'm having episodes every couple of months, and so my doctor's giving me 14 days of ciprofloxacin every time," or something like that, so that there's, I think, a concept that antibiotics, a more aggressive course, a broader spectrum antibiotic, when you've made that transition from a single episode of cystitis into recurrence, is gonna be the key to sort of kicking the cycle or reducing the likelihood of recurrence. How do you approach that recurrent patient when they come in and they're saying to you, I can you just make sure I have, 2 weeks of antibiotics on hand at any point because that's what I need?
You want to treat it the same each time. You're correct. There's that cognitive error that a lot of us make as clinicians. We've seen it in our studies. Well, since this woman has recurrent UTI and diabetes, she needs 10 days of Cipro because that's a stronger drug and she needs it for longer. That's not accurate. Each episode of cystitis you treat as cystitis. If it's Bactrim, that's your 3-day course. If it's nitrofurantoin, that's your 5-day course. Because treating longer is not going to keep bacteriuria from recurring if this person is predisposed to have bladder colonization. You want to treat long enough to relieve their symptoms, give the bladder mucosa a little break there. And then you can talk about, do you need suppressive antibiotics or do you need methenamine to try to reduce the episodes?
Do you have a favorite prophylactic approach that you will often try for some of these patients? And does that differ if it's a man versus a woman, if since you treat a lot of men?
Well, I think one difference is I don't really have access to pelvic floor therapy referral with
Mhm.
my men. But I think that's an important and only recently appreciated field of the recurrent UTI. I think that people who have a lot of UTIs start to get a very sensitized pain response in the bladder. And I think exploring pelvic floor therapy can be a really important path forward to help them understand when the pain is bladder infection, when the pain is something else, and have some management strategies for that. I think that's been a wonderful development in the field. Did I answer the question on that one?
No, absolutely, and then outside of physical therapy, what are some other prophylactic approaches that you support for your patients or that you like with your patients?
For years, I preached look for the trigger and use as few doses as antibiotics as possible, but treat like around the time of the trigger for recurrent UTIs. Some people, it's like long car rides because they don't drink fluids for 12 hours, or some people, it's sexual intercourse. And so then they can take a dose of nitrofurantoin after each time they have sex. So I try to get the dose as low as possible and usually give people like 3 to 6 months and hope that gives time for their bladder to heal and whatever nasty virulent strain of bacteria they have maybe gets replaced by something else. But now I'm using a lot of non-antibiotic approach with methenamine. I think the trials are encouraging. I still have a concern that they're not truly placebo controlled because methenamine has a very special taste versus the placebo pills. Um, but I think that there's a lot of evidence that it does give some relief at preventing recurrent UTIs. So I'm using that a lot.
Have you been using that in men as well?
Yes. Although they're
Oh,
not
absolutely.
included in any trials, but yes.
Yeah, I mean, I can't the mechanism should still theoretically work in anybody with a bladder. So, that seems very reasonable approach. As much as I think we have this kind of love-hate relationship with antibiotics, we both think that they're gold, like you said, but we also there's a sort of growing concern about, especially in patients with recurrent UTIs, about how many antibiotics they're taking and how that might be impacting their body. And I think I've really noticed that a lot of patients are coming in and seeking all kinds of other types of therapies, sort of natural or naturopathic or supplements. And what is sort of your view on why are patients really seeking those ideas and what is missing from the options that we have to offer patients that maybe we need to be thinking more about and working towards in the future?
Yes, thanks for asking that. That's one of the topics I really like to explore because I think that People are suffering. They have recurrent UTIs, they have continuous bladder pain. These things impact their quality of life, and the medical establishment doesn't really have solutions for them. And so I think that's why they are in some ways a vulnerable population. I think there are a lot of organizations that market to this large group of people with suffering, but with unproven or ineffective approaches. And, those things cost money. They're not harmless because someone is paying good money for them. So, we need to put more attention on solving this problem for people. And it's not just as simple as we need to get rid of the bacteria one time. It's what can we do to boost the host response so they're not so vulnerable to UTIs? What can we do to minimize the bacterial virulence so we could peacefully coexist with our bacteria? What can we do to target bacterial surface structures so they don't bind the bladder? I think there's so many different routes that we could be exploring to help the people whose lives are deeply impacted by recurrent UTIs.
What do you think are the biggest unanswered questions that we have still that we need to face in terms of improving our treatment, management, diagnosis of urinary infections? That's a big one.
Well, I love it. I think about this a lot. I actually have a whole graphic I call the wheel of UTI research because it's all related. But we don't know how to define when someone has a UTI that merits antibiotics. It's a continuum, right? Most people don't have a sterile bladder. Even if there are bacteria in it that day, don't we have a few viruses floating around? Maybe some friendly bacteriophage are hanging out in the bladder too, we don't know. And then some people walk around with low level bacteria and no symptoms or minimal symptoms. And then some people get horrible symptoms with low amount of bacteria and some people tolerate a high amount. And is there a way to get a biomarker that shows us if the bacteria is going to invade, particularly if it's going to invade into the bloodstream? Because that is where you really run into problems. If the bacteria in the bladder, the person can't tell you about symptoms, and the bladder is draining pretty well, like you intermittent cath or something, so you're getting all the bacteria out regularly, they do fine unless it gets into the bloodstream. So wouldn't it be nice if we had some kind of biomarker that would tell us if the patient was going to become septic, if the bacteria was really gonna hurt them, or if they were gonna be able to kind of peacefully coexist?
So, are there any biomarkers or any data that you've seen out there about these kind of predictive tests that are enticing to you or interesting to you?
I think all of the biomarker work right now is interesting, but what it's not gonna answer is the fundamental question of if or when an intervention would prevent bacteremia. And by what I mean by that is, you see a fair number of people, older adults who couldn't tell you about bladder symptoms, have bladder colonization most of the time, and they're being admitted with sepsis, and they are bacteremic, and it's probably a urinary source. So in them, that's not asymptomatic bacteria anymore. That's bacteremia. But if I had treated the asymptomatic bacteria in their bladder a week ago, would that have prevented the bacteremia? We don't know, right? We don't know if there is a point that you can intervene in someone who's predisposed to become septic and prevent it. And I think we need to put more attention at that. What is preventable? Does intervention help or not?
I think these are gonna be, really, really fascinating times that I hope will take us beyond our paradigm of just using antibiotics as treatment, but finding ways not only to modulate or ameliorate infections when they're happening, but also to kind of restructure our existence with bacteria, that coexistence in ways that make it easier for patients to get by without getting into this cycle of recurrent infection and then antibiotics, which doesn't really get rid of all the bacteria. In fact, may encourage the overgrowth of more pathogenic bacteria, may actually encourage the development of drug resistance and kind of encourage that cycle of recurrence. So I think all of these technologies in the horizon may be hopefully the key to getting us out of that pattern and into a more productive and manageable existence. Well, thank you so much for all of that amazing insight and for all of your perspective on UTI management, especially in some of these more challenging populations. So today we've talked with Dr. Barbara Trautner about some revisions to the guidelines and approaches to the management and diagnosis of complicated UTIs. So thank you so much for tuning in. Please take a moment to download the Medscape app to listen and subscribe to this podcast series on urinary tract infections. This is Dr. Lenore Ackerman for the Medscape In Discussion podcast.
Thanks for listening to Medscape's In Discussion Urinary Tract Infection podcast series with our host, Dr. Lenore Ackerman. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on urinary tract infections.